All right. My name's Tim Murphy, and I have the pleasure of introducing Dr. Acharya in about 5 minutes. So I want to tell you a little bit about the UB Community Health Equity Research Institute. I'm shortening what I had planned. Before I do that, I just want to congratulate Kelly and her team on that report. It is an epic report. And I would encourage you to have a look at it. I'd also like to thank and recognize Dr. Bashir, who really was the one who initiated this symposium. You know, this is a sign of the commitment of the highest level of our university, and a commitment that the university has to our community and to health equity and to addressing these problems. I think it's really important, and I appreciate those priorities. So I'm going to tell you about the history of our institute, but I'm going to skip that in an effort to move things along. But what I'd like to do is tell you 5 principles and priorities of our institute, several of which are a little bit different from what university researchers think about all the time. So our goal, and really what we want to do, is to address the social determinants of health with an emphasis in our community. So we're really focusing in our community. And one of the things, if we're going to achieve health equity, we need to address all the social determinants. It's estimated that if we could correct all the healthcare problems and healthcare access problems, that would move the needle by about 15%. And it's really the other social determinants that determine the health outcomes, the adverse health outcomes that our communities experience. So that means we need to engage people outside the health sciences. UB has 12 schools, and one of our goals in our institute is to engage investigators from all the disciplines that impact the social determinants. So the School of Law and the criminal justice system inequities, the School of Education, the School of Architecture and Planning for housing and neighborhoods and so forth. So our goal is to engage people from multiple disciplines. And whenever I talk about this, I'm usually talking to a group like this who has decided to commit an entire afternoon to thinking and talking and learning about health equity. So you're not the ones we're trying to reach, actually, a lot of times. So that's one of our challenges, and one of our goals is to engage people from more disciplines into this fight. Second thing is, and this is a principle, we're trying to influence how we in the Institute, how our researchers engage the community and work with the community. And if there's one word that I could emphasize, it's listen. You know, those of us in academic environments talk a lot. You know, we talk a lot. And we need to change how we do that and go in with an idea of listening. And what I like to say is, when you go into meetings with community members to talk about your research, go in with questions, not with answers. So that's a second key principle. A third is to involve the community, and Dr. Webb-Hooper talked a lot about this, and involve the community early on in the planning stages of a proposal, of a grant, of a project. Don't go into a community like many of our investigators have done. I think things are improving, but there still needs to work to be done. We're going to say, I have this great grant. It's going to really benefit the community. You know, will you help me with it? You know, I need data and that sort of thing, and then disappear when the project is over. We need to involve the community actively in the planning, in the performing, and the benefiting from our work. Our work in the Institute is focused especially on understanding and addressing the root causes. That's the hard part. I think that's the hardest element of the kind of research that we're all trying to do. We need to change systems to change those social determinants, not Band-Aids, but actually address and come up with innovative ideas to change systems that we haven't been able to do for 400 years. And then lastly, and it was the question that I asked Dr. Webb-Hooper, is, you know, we need to keep in mind, how does the community benefit from the research that we're doing? We get grants and we get manuscripts and so forth, and people earn their PhDs and so forth. And then, you know, we need to keep in mind that once that work is done, then how is that going to be implemented in the community to actually improve and to address these health inequities that exist? So addressing all the social determinants, listening, involving the community from the beginning and in active ways, address root causes, and then keep in mind that the goal of what we're doing is for the benefit of the community. So those are the principles and the priorities that we have in our institute, and we welcome participation in any ways that people would like to participate with us. So with that very brief summary, it's my privilege to introduce Dr. Karabi Acharya, who Dr. Bashir introduced, but given the fact that sometimes our short-term memories are short, I'll give an abbreviated introduction as well. We are really privileged to have Dr. Acharya join us. She is Senior Director, Equity Lead, and leads the Global Ideas for U.S. Solutions teams for the Robert Wood Johnson Foundation. She has training and expertise in anthropology, public health, systems thinking, and among other degrees, has earned her Doctor of Science from the Johns Hopkins School of Hygiene and Public Health. She's written and presented extensively on a broad range of issues related to health equity. Dr. Acharya directs the Foundation's strategies for global learning as it identifies best practices in other countries, adapting them to improve the social determinants of health in communities in the United States. Prior to her time at Robert Wood Johnson, she's worked with the Academy for Educational Development to bring community voices and perspectives into the policy and program design. And I have to say, Dr. Acharya, I love the title of your talk, Unleashing Our Collective Imaginations, Global Learning for a More Equitable Buffalo. So please join me in welcoming Dr. Karabi Acharya.
Thank you so much for that really kind introduction. And thank you so much for having me, and good afternoon, everyone. It's a pleasure to be with you virtually today. I'm sorry I couldn't be there in person. But you know, in the age of Zoom, with the click of a button, we can span time and distance, and you know, the world is literally at our fingertips. And at the same time, we often don't find the time or the motivation to travel, either in our minds or with our feet, to other parts of the world and to see what the rest of the world has to offer. In fact, in my field of philanthropy, about 66% of US philanthropies rarely or never look abroad for ideas to inform their grant making. So we're trying to change that, and I want to share a little bit about the work that we're doing, and how it may relate to your work in Buffalo. So thanks again for having me. I want to start with a short story of a trip that I took to Cuba a number of years ago, maybe 5, 6 years ago, before pandemic. And this was organized by a group called MEDIC, which takes groups of people to Cuba to learn about the Cuban healthcare system and public health system. And you may know that Cuba has greater life expectancy and lower infant mortality than the United States, with, of course, a fraction of the economic resources that we have. They are doing a lot of things right in when it comes to health. And so we, with MEDIC, took a group of US practitioners, health practitioners and community leaders, people working in primary care and preventive care, in under-resourced communities in the United States. So it was a group of about, I think, 20 of us. If you could go to the next slide, please. One of the things we did on that trip is we visited a public park. This is just, you know, an average public park in the middle of Havana. And you can see here, there was a group of older women practicing Tai Chi. In the background, you can see a couple of school groups. They were having recess and PE. There was another group of pregnant women doing an exercise class. Overall, we counted about 7 different groups, some community groups, some just local groups of people, some with the school, including a school for disabled kids. All of them were using the park. And one of the women on the trip was a woman who worked at a clinic in the Bronx. And she turned to me and she said, "You know, there is a park right next door to my clinic. And I have a friend who's a Zumba teacher. And I never thought about the potential of using that park for our clinic or anything related to the programming that we do for primary and preventive care." And what struck me and what struck her was, why did it take coming to Cuba to see the park that was right next door to her clinic? Why did she have to leave her home and her place of work to see what was available right next door to her with new eyes? And we found that that is often what happens when you embark in global learning. When you leave your home, either literally or figuratively, it's sometimes you can look back on your home and see it with new eyes, and you see things in a different way. And through that process, you can begin to imagine new things. And I guarantee you, she went home planning to call her friend who's a Zumba teacher and planning to set up some exercise classes for the folks in her clinic. When I titled this "Unleashing Our Collective Imaginations," that is one of the greatest, I think, gifts that global learning can give us. Of course, lots of good pragmatic ideas, but I think most importantly, it's just this idea that the way that we do things in the United States is not the way that we have to do them. There are many options, and we can begin to think about things differently. So today, in our few minutes together, I wanted to take us on a brief tour around the world to see the world with new eyes, and in doing so, maybe see some new possibilities in our own communities. There is so much, and if you can go to the next slide, Jill, sorry. Um, there is so much that the world can teach us, certainly way more that could be covered in one talk. And so what we did is we asked the organizers about some of the issues facing Buffalo, and wanted to see, what could we find around the world that might be relevant and to some of the issues that you're facing in Buffalo. And so I'm going to touch on a few of those. So next slide, please. So, access to healthy food. So, sadly, Buffalo is not alone when it comes to a lack of access to healthy food for everyone. Around the world, more than 3 billion people are unable to afford healthy food. That's 2020 data. And during price shocks, the cost of nutrient dense food often increases more than food that's of poor nutritional quality. And of course, we all know that nutritionally poor food increases the risk of diabetes, obesity, cardiovascular disease, and sort of the list goes on. So I want to take you to three countries who are trying to change this. So next slide, please. So Discovery Health is the largest private insurer in South Africa. And what they do is they provide rebates of up to 25% on healthy food purchases at about 400 different supermarkets around the country. So when you join with there's a free membership, and you start off getting a 10% rebate on those foods, and then once you've filled out a health questionnaire, that increases up to 25%. So that's Discovery Health, the health insurer innovation. Next slide. In Singapore, they are all about urban agriculture. You may know only that Singapore, of course, is sort of a city nation, and only 1% of their land is farmland. And so that means they have to import over 90% of their food. But when food supplies are disrupted, of course, many families, increasing numbers of families become food insecure. And so now Singapore has set a goal of producing 30% of its food locally by 2030. And how are they doing this? They are literally planting produce and herbs and all kinds of food inside buildings, on rooftops, and even on walls. Next slide, please. In Kenya, the Kenyan Ministry of Agriculture, Livestock, Fisheries, and Cooperatives has launched the 1 Million Kitchen Gardens initiative. And there the goal is to support households, mostly urban and peri-urban households, to grow fruits and vegetables and herbs. And they provide them with what they call a kitchen garden kit. And so that, of course, supplements the food, the healthy food that's available to these households. And it also relieves some of the strains on the Kenyan food system. Next slide. So housing, again, access to affordable and quality housing is a global issue. I understand it's an issue in Buffalo as well as in so many parts of the United States. Globally, 3 billion people are going to need access to affordable and adequate housing. And that would require building 96,000 new homes per day until 2030 to meet that need. So I wanted to take you to a couple places that are doing some interesting solutions. So next slide. So in Toronto, there's an organization called the Housing Help Center, and they work with immigrants, with permanent residents, and refugees to help them find housing and to acclimate to life in Toronto. It helps folks to apply for subsidized housing, pay rent, utility bills, and it hosts a lot of information sessions around navigating housing and other social systems. Next slide. In Vienna, Austria, they have been building what they call social housing, which is essentially government subsidized housing, for over a century. And this housing program, their social housing program, is known for its architectural innovation. You can see this amazing complex in the photo here. High quality and financial sustainability. And get this, today, over 60% of Vienna's population lives in social housing. So this is not a form of housing that is in any way stigmatized or considered less than. It is a highly valued and desired form of housing in Vienna. And this is managed by the municipality and also by a number of housing nonprofits. Next slide. In Jordan, the Urban Shelter Project works with owners to refurbish homes that have been deemed sort of uninhabitable. And these, once they are refurbished, these homes are leased rent-free for 18 months to Syrian refugees. And the funds that are used to refurbish these homes help to provide jobs. And so it provides added sort of inputs into the local economy. And also it helps to reduce conflicts between the local folks and the refugees. And to date, over 5,000 housing units have been improved, providing housing for over 18,000 refugees and creating over 20,000 short-term jobs. That is a win-win-win situation. Next slide. Transportation. We know that transportation is often an overlooked social determinant of health, but of course, we know if you can't get to work, school, or your doctor, your opportunities for better health are hugely impacted. And even if you do have access to transportation, sometimes it's unreliable or even unsafe. So there are some countries in South America that are doing some interesting work on transportation. So next slide, please. So this is one of my favorite examples, I have to say. This is in Ciudad Bolivar, which is a part of Bogota, Colombia, and a particularly poor part of Bogota, Colombia. And this is an area where a lot of domestic workers live, a lot of people who are, in service jobs, and they have incredibly long commutes to get to work. And what they did is they built this transmicable system, this cable car system, which has cut access, the commuting distance down to just 19 minutes for many folks, which is, less than half of what folks were having to do before. Of course, it also reduces traffic congestion. And one of the things they did is while people are commuting on the cable car, the city has funded art and kind of colorful paint on houses and created murals so that you're seeing that as you are traveling in this cable car. And then at some of the stops where the stations where the cable cars are, they have co-located a whole range of social and legal services, even laundromats and other things that are kind of just core daily services that are needed for lots of these folks. So I confess I have dreams of, cable car systems over, I don't know, Manhattan or LA or even Buffalo. So I love this example. Next slide, please. Um, yeah, next slide. Yeah, thanks. So in Quito, Ecuador, they're doing some really interesting work around the issue of gender equity and transportation. You might not think that transportation is a gender issue, but what they found in Ecuador and of course in many other places as well, including places in the US, many of the people, in fact, often the majority of people using the public transportation system are women. And in many places, and this was true in Quito, um, women are harassed and even assaulted while they are on public transportation. And so what Quito has done is they've established a large communications campaign and a policy effort to respond and to prevent sexual harassment on public transportation and on their buses and on their rapid transit system. And at some of the bus stops, they offer services, legal and social services for women who might be dealing with some of these issues. So it's a great way of sort of thinking about transportation, but from a gendered perspective and understanding the needs of particular populations who are using those services. Next slide. So at the Robert Wood Johnson Foundation, we are very committed to dismantling structural racism, which is at the root of so many of our health disparities and indeed so many of our national ills. And of course, it's directly related to many of the issues that we've just talked about, from transportation and food to housing. And part of dismantling structural racism is really in understanding our history and how things came to be the way that they are. And so I wanted to share just a couple of examples of how we're beginning to do this and how other countries are beginning to do this. So next slide. So I know there's a lot of health folks in the room, but I'm wondering how many of you know the story of the origin of the body mass index, um, uh, uh, s- data point and statistic. You may not know, but it started in 1832. A Belgian statistician named Adolf Quetelet, he calculated a body proportion formula that defined sort of the average or normal man at different ages based on data from a group of Belgian men. Insurance companies picked this up and they began using this for their actuarial tables. And then in 1972, Ansel Keys highlighted this work and he adapted it and he renamed it the body mass index. Now that the body mass index was never intended to be used at an individual level. It was always intended to be used at a population level. Um, and one of the problems with it is that if you look at this photo, these are the kinds of people who this data is based on. And as we know, most people in the world don't look like Belgian men. And that was the sort of the data pool upon which the BMI was based on. And you know, a lot has been written about this, and you know, I think that without knowing that history, without understanding how some of these measures came to be, we might not understand some of the embedded bias that is in some of these biomedical measures and tools. Japan has dealt with this by instituting what they call the Metabo law, and that requires that at annual checkups that healthcare providers use a much broader array of examinations and tests than BMI for to sort of assess health. So I just wanted to highlight that because especially with the COVID pandemic, BMI has become such a short proxy for so many things, and it may not always be the best or most accurate proxy depending on the population. Um, Next slide, please. So I'm going to play a short video clip. This is an example um, of what is happening in has happened in New Zealand. So, you know, I think that, you know, again, too often when we think about our own history, our own problems around structural racism, it can sometimes feel intractable. It can sometimes feel hopeless. But I want to share a little bit of what New Zealand has done because I think there is hope and inspiration in understanding how other countries have confronted their own histories of racism and discrimination. So I'm going to share just a short clip of what you'll be seeing is the government of New Zealand, which they call the Crown. So you'll hear reference the Crown this and the Crown that. The Crown for them means the government. And they're making a formal apology to the Maori people as part of a settlement agreement that they reached with the Maori. So Jill, if you could play that clip. I don't know if the sound is. Yeah, I'm not hearing. Are other folks hearing the sound or? I can't hear. We can always
Could
share
hear
the
it.
link.
Can you hear me?
I can
Can
hear
you
you.
hear me?
Yes.
Okay. I'm sorry that for some reason the PC audio wasn't connecting online, but we could hear it in the room.
Oh, okay. All right.
Okay,
Perfect.
sorry. So I just let it run through to the time point where you told us to stop.
Okay. Perfect. Perfect. Okay. Great. And we can share. This was created by Vox Media. They're a program they have called Missing Chapter. So we can also share that link afterwards for folks who couldn't hear it. So thank you for that. So I think the last example that I wanted to share around dismantling structural racism comes from an interview that I did recently with Dr. Taleng Mofukong. She is a part of a commission that is exploring what countries around the world are doing to address racism. She's a South African physician and activist, and we did a write-up in the Stanford Social Innovation Review. And I just wanted to share, read you a piece of what she said in response to a question that was very powerful to me. So if you'll indulge me, I'm just going to read this. Another important theme baked into our approach is this idea of restoration of dignity. And that means we are probably going to have to do a lot more work with people who are rooted and located within communities. We must be intentional about amplifying the voices of and solutions from people experiencing these issues in very real ways in their daily lives. There are people every single day who are fighting racism, who are struggling with racism, and who are surviving. And there are things that they can teach us as they continue to survive. And it's that humility that's required to be able to do this work with the intention to support and restore the dignity of people. All right, next slide, please. All right, so what now? In about 20 minutes, we have traveled to 9 countries on 6 continents. It was a whirlwind tour. I hope you're not too jet lagged. But you might have doubts about, well, these are all interesting examples, but can any of them work here? Can any of them spread to the United States? And to answer that question, if you could go to the next slide, I want you to think about these 3 things: toothbrushes, kindergarten, and vaccinations. These things are as American as apple pie, I think, today. They are an integral part of American life for children under 5, and for some things for all of us. But how did they come here? How did they start? They were each started in another country. Toothbrushes came from China. How did it end up being ubiquitous in the United States, where it is such a part of our culture? Their spread took time, but it required champions and networks. It required people like all of us to pick up an idea and run with it and help it to spread. And it often starts with asking a few questions. So if you go to the next slide, in Cardiff, Wales, an emergency room doctor was noticing that late at night, around 11 o'clock at night, there would be a huge influx of patients coming in with severe lacerations. And it kept happening every night and around the same time. And he started asking himself, like, why? What is going on? And he reached out to the local police and he said, what is going on? Why is this happening? And they started tracking where these injuries were taking place. And lo and behold, they found out that, guess what? The bars and pubs close around 10:30 all at the same time. And so you have some inebriated people, and there are some altercations. And what do? They pick up their beer bottle or their bar glass, and they start, kind of throwing them around on people. And so that was what was causing this influx. And so then we were all ending up in the emergency room to get treated. And so the ER partnered with the police and was like, okay, well, what are we going to do? And they came up with 2 incredibly simple solutions. The first was, starting at 10 o'clock, they serve all drinks in plastic cups. So you've immediately removed the weapon, so to speak. And then they also started staggering the closing times of the pubs and required that that not all pubs close at the same time. This idea and this idea of working of ER departments working with police to identify hotspots of violence, which is now called the Cardiff model, has come to the US. It is now in, I think, 3 or 4 different American cities: Atlanta, Minneapolis, and Philadelphia. And it has been, again, remarkably effective. Sometimes it's as something as simple as putting up streetlights to ensure that, you know, violent incidents are not taking place. So this is, you know, an example of an idea spreading. Next slide, please. But if you're still skeptical, I want to share one last example with you that is right there in Buffalo. Some of you may recognize this park. I sadly I've only driven through Buffalo, so I can't be of help there. But I have been told that you all get some snow in the winter. And there is an organization called 880 Cities that wanted to work with cities um, that have pretty harsh winters to try to recapture public spaces, to try to get people active and out and about in the winter. And so 880 Cities wanted to take inspiration from a number of Nordic cities and bring those ideas into 3 US cities. And one of those US cities was Buffalo. And yeah, I don't know, maybe some of you in the room were involved with this. It was called Winter Mission. What they did is, well, so first of all, the purpose of this was to get people more physically active, but almost more importantly, to combat social isolation, which of course can be particularly difficult during the winter months. And so, what they did is they had a number of community engagement efforts throughout Buffalo, pop up meetings and interviews in coffee shops and campuses and public libraries, and tried to engage people to understand, you know, what are the needs that you're seeing, what would you like to see happen during the winter? And they came back with 4 areas that were really important to people. The first, again, sometimes it's the simplest things, but the first was just better snow removal and maintenance. And that spawned a whole bunch of sort of volunteer efforts to deal with snow removal. The second was just more heat in bus stops, thinking about fires in parks. And so I think there was some loosening of some of the local um, ordinances around sort of using fire in parks. So this is an example where they're making s'mores in a public park. Um, a third area was programming. Just have more events, more music, more art, more programming for people in the winter months. And then the last thing that was particularly important to folks in Buffalo that came up was inclusion and thinking about the reality that, you know, winter gear can be very expensive, and thinking about how do we ensure that recent immigrants or low income folks can have access to the winter gear that is needed to fully participate in winter activities. So if you had any doubt that global ideas could land in Buffalo, in fact, of course, they already have. Um, Next slide, please. So I hope this talk today has opened your imagination a little bit to what the world has to offer. Our tagline is that good ideas have no borders. That, you know, I think there's a lot of hope and inspiration from those global ideas. And some of those might be useful for building a more equitable future for all in Buffalo. So thank you again so much, and I'm happy to answer questions.
Thank you so much, Dr. Acharya. That was terrific. Really brilliant ideas that these other places have actually implemented. A lot of lessons there. Questions?
Thank you very much for a terrific talk. Lots of great ideas. And so one thing I was thinking as you were describing those different examples is that many of the interventions went beyond health. Transportation, housing, these are not the typical strategies we test in our randomized clinical trials. So what kind of teams and partnerships does it take to be able to create, test, and implement this very effective and very strategic interventions?
Sorry, I was muted. Yeah, no, great question. And, I think that for us, we take at RWJF, we take a very holistic view of health and think about the social determinants of health broadly. And we find that in many countries, some of the most effective health interventions come from areas that are far outside of what is traditionally health. And I think that often, I think our role in public health is often to help others in other sectors understand that, you know what, putting in streetlights can save lives. Changing transportation systems can save lives, and helping them to understand that the work that they are doing has huge health implications. We know that healthcare and the healthcare system accounts for about 20% of health outcomes. And the rest of health is where we live, learn, work, and play, as we like to say at the foundation. So we need to think very holistically about where are the opportunities to think about things outside of the healthcare system that can improve health. And so I think one of the things that has been successful in many parts of the world is this kind of cross-sectoral collaboration where for the Cardiff example is a perfect one. Folks in the healthcare system working with, in that case, law enforcement, as well as community groups, to identify violent hotspots and then working together to find solutions. And like I said, one of the solutions, I believe this was Atlanta, they identified a number of violent incidents were happening in I think a particular parking lot, and the solution was better lighting. And the minute they put the lights off, now of course, maybe it shifted somewhere else or whatever, but it is remarkable how things that we may not think of as being part of health actually have tremendous health impact. And so I think moving outside of the clinic and understanding people's lives in its full entirety is absolutely critical, and it's what so many of these examples were about.
So thank you so much for all the work that you're already doing. And my question, which is very related to the question just asked, which is, as the Robert Wood Johnson Foundation is so well known as a funder, and yet some of these things, they can be transplanted, but they're also very ingrained in the local community. And so they may be much smaller. So I'm just wondering, what kinds of things are you looking at? What kinds of parameters and characteristics are the things that you're looking at when you're looking at these grant applications for projects?
Project. And I should be clear, the examples that I gave, I'm trying to think, almost none of them were funded by us. We don't fund things where the impact is outside of the US. So I want to be clear, these were examples that we've learned about, but we were not sort of directly involved in supporting or anything like that. So I do want to make that clear. Within my portfolio, which is essentially global learning, it's called Global Ideas for US Solutions. We are interested in helping people in the United States, practitioners, community leaders, policymakers, a whole range of people, healthcare system folks, we're interested in helping them to learn about what is happening in other countries, and to build relationships with folks in other countries. And, I will say when this work began, initially we thought, oh, we're going to find a really interesting programmatic approach or an interesting policy, and we're going to find those, we're going to adapt them, and then we're going to replicate them in the US. That was our, somewhat, I think, naive start to this. And Cardiff was actually a great example of that. That was a programmatic approach. It had been evaluated and had tremendous impact across many countries. We helped to bring it to the US, and but we found that is actually almost the that's only one reason to do global learning, what we would sort of call the very pragmatic approach. There are two other really important reasons to do global learning, and the second one I'll mention is peer support. So recognizing that the fights and the challenges that we have in the US, many of them are very similar to challenges in other parts of the world. And we've just gone through, housing, transportation, food, structural discrimination. And what does it mean if you have, so I'll give you an example. We brought a delegation of people, Americans working on birth justice, to a global conference in Rwanda called the Women Deliver Conference. And one of the most amazing things of that trip was these American leaders, who most of whom had never left the country, are suddenly in a global community and seeing that their fight, so to speak, is a global fight, and they can gain inspiration and solidarity and learn and just camaraderie for the global movement on women's health. So that peer and support, community support, is incredibly important. And then the last thing I would just mention is sort of the moral imperative. If you think about whose knowledge counts in today's world. And, we have grown up in a particular system that says that people with degrees, people with brand named institutional degrees, that their knowledge is more important than someone who has lived with a particular issue their whole life. And I think we are trying to adjust that power dynamic and say that, what, people in communities, people with other ways of understanding and knowing about the world, that is legitimate information and a legitimate way of knowing, just like, the more traditional scientific ways of knowing. And so beginning to understand that, and to understand that, we have that we don't often include, for example, indigenous ways of understanding health and illness and things like that. So I don't know if that fully answers your question, but that's a bit of like why we do global learning, and what we are, what our sort of larger objectives are in our kind of investment strategy on the global team, that is.
One more question.
I appreciate that your portfolio includes global learning, and that was evident in a wonderful presentation. So thank you. RWJF announced a rather sizable investment in health equity earlier this week, and I was wondering if you could speak to it, but also then perhaps comment on how that fits into the larger funding and strategy that RWJF has.
So I have to confess, I'm not totally clear on what you're referring to, but I will say, in terms of what the new investment is, and my only excuse is I've been out sick. So, but I will say that health equity is at the center of everything we do. We are our mission, our vision is around achieving health for all, focused on health equity. So there is really nothing that we do that does not put equity at the center. And increasingly that has meant a focus on, as I said, dismantling structural racism and understanding the role that structural racism has had in creating health inequities, and how do we begin to understand that and repair that. But I'm afraid I just don't know the specific funding opportunity that you're referring to, so I'm afraid I can't be more helpful. But like I said, health equity is at the center of absolutely everything we do.
Thank you so much, Dr. Acharya, for visiting Buffalo remotely.
Thank you so much for having me.
And Dr. Bashir.
Great. So thank you again. We really appreciate your talk today. I want to thank all of our amazing speakers, Kelly Wolford, Dr. Acharya, and Dr. Monica Webb Hooper. It was amazing. It's really been an amazing chance to share. So I have one more thing to share before you all leave. I want to introduce Dr. Leonard Aghetti, who is our new chair of internal medicine, and will start on July 1. Dr. Aghetti is the division chief of general medicine at the Medical College of Wisconsin, and he is going to join us July 1 as the chair of medicine, and is already busily moving several members of his team here. He has over $20 million of NIH funding, almost all in health equity, and over 400 publications in the similar vein. And so we're really thrilled to have him join the Jacobs School of Medicine team, having a robust department of medicine that's engaged not only in research, but research that's impactful to the community is just huge. It really helps us carry our mission to improve health. So I told Leonard I would ask him one simple question, and then so I wanted to know, Leonard, about what you can bring from your experience at MUSC, which is in Charleston, and then in Wisconsin, and what maybe you might see as an opportunity to come and bring to Buffalo, and maybe some of the challenges, because you've got lots of friends here in the audience that are willing to help.
Yeah, so I think I was just listening to the conversation, and we, for years, have had similar equity conferences, and it's usually a chance to get people to engage and really get insight into what's happening. So when I was in Charleston, I think I spent 17 years just trying to understand equity issues, but it was more from the lens of rural urban disparities. And so we did a lot of work looking at telemedicine and strategies. And then eventually, when I moved to Milwaukee, we actually had to shift focus, really focus on more of the urban area, more inner city challenges. And so first 2 years in Milwaukee, we essentially spent it doing deep work. We did mostly about 350 interviews, 50 focus groups. We did a photo voice, and then we did about a survey of about 2,400 individuals. So we actually had a very deep understanding of the issues in Milwaukee. And then that was we then used that as a basis for developing interventions. And so coming to Buffalo, and I'll talk about, kind of the lessons learned from Milwaukee, which are very translatable to Buffalo. But more importantly is the interventions we've actually developed. I know someone was asking, can you fund social programs? And we have a robust funding stream that really focuses on the medical social integration. How do you actually do that? So we have a grant, an RO1 that's focused on financial incentives and how do you incentivize patients to change behavior. And that grant is actually looking at not just giving people money, but actually tracking what happens to the clinical outcomes over time. And then we stop the funding, and we're actually going to track after about at 18 months, where do people move from from extrinsic motivation to intrinsic motivation. So just a different way of thinking about how do you get people to change behavior in a meaningful way. The second grant that we actually are working on finishing up right now is looking at elderly, and where you're actually looking at social isolation and how do you help them address, so taking care to them instead of them coming to the clinical environment. So we address social needs, we address social risk factors, and we actually have nurses and teams that go out to them in the community. And we're actually tracking that as a model of home-based care and how do we provide care to individuals who are older, who are more challenged. And then we have a third grant that is focused on food insecurity. And we're testing food supplementation. What's the best way to do food supplementation? Do you give stock boxes? Do you give vouchers? Do you give a combination? And we've already learned we're finishing up the grant right now. And it was very clear that boxes do not work. People don't like the boxes. They actually want to be able to be given cards, vouchers that do not stigmatize them. There's a very high stigma with food insecurity. So we actually are developing a stigma scale to really help people identify ways to actually ask those questions without stigmatizing the individuals. And then a couple of our mentees, actually one is looking at universal basic income. And the idea is, and this is one of the questions that keeps coming up, can you pay for services? And the idea is this study is looking at giving about $500 every month, and we're looking at what is called conditional cash transfers. And the concept is that when people are poor, they don't have the resources to take care of their basic needs. And when they don't take care of basic needs, health outcomes are poor. And so the idea is to test this concept that if you actually provided those basic resources for basic needs, would they be more focused on addressing health issues? And then we condition it on attending classes and getting some clinical conditions addressed. And so that study, we've had a very robust participation in that study. And then we have a fifth study right now that's looking at using income supplementation plus food supplementation and to really look at food insecure individuals. So the point I'm trying to get across is that Buffalo is going to benefit from kind of that whole framework of how do you actually do medical and social needs integration in a way that is fundable and in a way that actually would shift policy, because the goal is to change how we provide care to people who are less advantaged and what kind of evidence can we generate. And then the last thing we're working on, 2 other grants we have are structural racism grants. And these are grants that are looking census tract data to look at how do we actually identify pathways, and we are using multiple measures of structural racism. We have the ability to now look at geocoding and look at multi-level processes, and then identifying pathways. What are the pathways? And then if we can identify those pathways, can we then create policy change that would then revert or at least modify or mitigate some of those issues? So those are some of the work we're doing, and we're hoping that we can actually come to Buffalo and be able to kind of accelerate the work we've done and really help support what people are already doing here.
That's great. Well, we're thrilled to have you here. Thank you so much. I want to thank Dr. Jill Cizek. Where'd she go? There she is again. Can we give her a round of applause? She took a red eye from a study section to be back here today to run this symposium. So she's amazing. I want to thank all the participants. We will have an AI symposium. That will be the second one that we're doing. It's going to be the first week in October. And if you haven't heard, there's something called Empire AI that will make it incredibly exciting. I want to thank you for your participation. Thank you for your commitment, and thank you for your passion to really make an impact. This is such an important topic.